Yeah, 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 and I have this other. I get
Yeah.
yeah, I got it. Yeah, that's interesting.
All right. We have a quorum. So again, I want to thank everyone for coming for the second meeting of 2018. So first we have approval of the minutes of the January meeting. Are there any additions or subtractions?
So moved. Second.
Okay, so there are no additions or captions, so all in favor?
Aye.
All right, so now, we began the last time, or the last couple of times, two very important discussions. One is the proposed transaction which would bring together two important and large healthcare delivery systems here in Massachusetts, Lahey Health System, BI, Deaconess, and I guess also brings together Seacoast Regional Health System. And the second is later down the road is our continued discussion and open in terms of our healthcare cost trend report. So we're going to start off. I'm going to turn it back over. I'm going to turn it over to David. We'll turn it over to real people that are making the important.
All right, thank you, Mr. Chairman, and good afternoon, everyone. Good afternoon, commissioners. This is our third board meeting in about 6 weeks, and really with today's meeting, wanted to go back and revisit some really important topics from the December board meeting. The December board meeting was a very packed agenda, and we moved through some issues very quickly, and wanted to provide an opportunity for the board and commissioners to discuss and deliberate at more length and in more depth some of these important topics. So today we have a more limited agenda for us in terms of a board meeting, and really do want to provide an opportunity for us to kind of slow down a little bit and provide an opportunity for questions and conversation, specifically around the two issues that the chairman just mentioned. One is the transaction which is before us for review, Beth Israel Lahey and a host of other parties, which we'll talk about, as well as finish a presentation on findings from the 2017 cost trends report, and then want to have a conversation with board members around what types of policy recommendations we would like to include in that cost trends report for publication later in February. So those are the two main agenda items, and as we go into specifically the Beth Israel and Lahey discussion, I will just note at the top, on many of these slides and the information that we're going to walk through is a repeat of what we did at the December meeting. But again, we'll go through it at a little bit of a slower pace and answer questions along the way to the extent that we can. We do have gotten confidential production from the parties, but that came in very recently, and we have not had an opportunity to analyze that information as of yet. So there may be some questions that we will not be in a position to answer today, but we'll absolutely take into account as we continue our review. So to begin our section under market oversight and transparency, and we have reframed our agenda along with the two committees here that we have restructured the board around. We'll start with our update on notices of material change, and so Deputy Director Megan Wolf will just walk through where we are with some of our notices.
Thank you, David. Since 2013, the HPC has received notice of 90 provider transactions, with clinical affiliations the most frequent, followed by physician and hospital affiliations. We currently have 3 notices under review, as you can see on this slide, 2 of which were received since the last board meeting. These include the proposed acquisition of the non-hospital-based diagnostic laboratory business of Cape Cod Healthcare by Quest, and 2 proposed transactions between Shields Healthcare Group and subsidiaries of Wellforce. The first, a joint venture among Shields, Hallmark Health System, and Tufts Medical Center Physician Organization to build and operate a freestanding ambulatory surgery center in Medford, and the second, a clinical affiliation between Shields and Tufts Medical Center to manage MRI services at Tufts and at Shields sites in Dorchester and Dedham. We also elected not to proceed to a CMIR for 2 transactions, the acquisition of IASIS Healthcare Corporation by Steward, and a joint venture between Shields and Bay State Health to operate an urgent care center near Springfield. For each of these transactions, our review suggested limited scope for increases in healthcare spending in Massachusetts, and we did not review evidence suggesting negative impacts on quality or access. We have one cost and market impact review in progress, and I'll turn it over to Kate to speak more about this transaction.
Before we go there, can we just pause for a minute? Sure. A lot of these transactions involve Shields Healthcare Group, which we've never looked at all. Anyway, and I'm just curious, is that, as we go back to our transactions, is it just that we're getting them now, or is there a lot of activity related to joint arrangements between providers and existing providers and Shields that I should just be aware of?
We've received a number of material change notices regarding Shields over the course of the time that we've been receiving material change notices. So that's not a new thing as of now. Many of those have also been going through the DLN process, so there's been a number of public reviews about Shields. Happy to answer questions about those. I'll note that Shields has shifted recently. Historically, it has been primarily in the imaging business. We have been seeing obviously, we're looking at an urgent care center here. We've looked at an ASC recently as well. So that is kind of a new area of the market that Shields is getting into.
But I would note, we have seen a pattern of Shields engaging with provider organizations in joint ventures, where they both have a share in that venture, whether that's imaging, surgery, and that, I think one of the first ones we received on this was UMass Memorial Hospital a few years ago, and this certainly is an increasing market activity.
If it were easy, could we just have like a one-pager on the extent to which various Shields is engaged in various type of joint ventures and own arrangements across Massachusetts?
Can I just, the Cape Cod Healthcare and the Quest Diagnostics has been on here for quite some time. It's something that's under review. Is there an update of where we're at under that review? The clock started for 30 days. Where are we at?
So we actually just received the transaction documents from them very, very recently. So we are at a staff level going through those to make sure there aren't outstanding factual questions. So there's often a number of questions that we have once we've gone through those materials in depth, and we deem the notice complete once we kind of have that full factual background. So we aren't quite at that step yet because we haven't finished that review, but will be very soon.
Thank you.
Great. Seeing no other questions on the pending material change notices, we're going to shift now to dive in a little bit more in depth on NewCo, the transaction before us. And so, again, I really want to emphasize, please stop us along the way and ask questions about the different moving pieces here. Important to understand kind of all the different mechanics of this transaction, but also to then think about how this transaction is going to reshape healthcare as a whole in Eastern Massachusetts. And so we'll talk a little bit about how their market shares, specifically in inpatient, outpatient, and primary care, we project them to change as a result of this new organization. We'll talk a little bit about that later in the presentation. I'm going to turn it over to Kate to kind of go through some of the details here of the transaction.
Thank you, David. So these slides should look familiar. These are many of the same slides that we presented in December when the board voted to initiate the cost and market impact review. We're hoping really just to use them as a jumping off point, though. So please do feel free to pose your questions and begin discussion with these things in mind. And then also, as David noted, we've recently received a large amount of material from the parties confidentially in response to our information requests. There may be questions that we can't answer because we haven't completed a review of those materials. There may also be questions we do know the answer to, but because it's in confidential material, we can't discuss it publicly. So we can follow up with commissioners individually if there are questions we can answer outside of this forum. So as a refresher, there are kind of two major pieces of this transaction. So the first one is a proposed corporate affiliation, essentially a merger, encompassing full economic and clinical integration of the parties that you see laid out here. So this is the Beth Israel Deaconess System, including the BI Medical Center, as well as its 3 community hospitals, the Lahey system, including Beverly and Addison Gilbert hospitals, as well as Winchester Hospital, as well as Lahey Medical Center itself, and the 3 currently independent hospitals listed to the right. And you see in the asterisk there, those 3 hospitals do have existing important relationships with the parties. So both Anna Jakes and New England Baptist currently contract through the BIDCO network. And New England Baptist and Mount Auburn Hospital, along with the BI system, are part of Care Group. And so they do have a corporate link now. However, Care Group to date has not involved any joint contracting. So that's why, if you recall, we did a cross-market impact review in the past when New England Baptist was going to begin contracting through BIDCO. Even though they had this corporate relationship, Care Group didn't do any of that contracting. It wasn't a clinically integrated network. It was really a system that allowed them to borrow together, et cetera. Pause there if there are any questions before I kind of go on to the second part of this transaction.
Quick question, when you receive information, does that include pro forma statements? Because I know we're always looking at, will costs increase, how can they cut costs? Are you receiving pro formas and are they being reviewed by third parties?
Yes, so we ask for a wide range of information, data and documents. So we receive things in the format of both written descriptions as well as detailed spreadsheets. We work with—
Those are projections.
Correct.
Over a 5-year period of time, how does that work?
We ask for them over multiple different timeframes, and off the top of my head, I don't recall exactly the timeframes that have been provided. But we do ask for their impact projections and to detail the mechanisms that kind of go into that.
That's different than looking at actual statements. Every organization will, when you're looking at an acquisition, they're going to make very specific projections, and they'll look like standard financial statements where we can easily compare existing statements with what they're projecting.
Correct. We also have access to all of their existing financial statements. And
As well as their projections.
Correct. Correct.
And acquisition costs?
Yes, all of that is part of the transaction materials. And so any costs related to acquisitions comes to us in the format of the underlying documents governing that transaction.
But since these are nonprofits, as an example, there's no stock. And the acquisition cost comes in a different form.
Right.
And I think it's really important to know what that is, because we need to bake that in when you're making your evaluation, right?
Absolutely. So the other major part of the transaction under review is a contracting affiliation. And so as part of this material change, the parties propose that their current contracting entities, so that is BIDCO, the Lahey Clinical Performance Network, the Lahey Clinical Performance ACO, would all be acquired by NewCo. And over time would essentially be contracting together. As part of the transaction, they would also begin contracting jointly with Mount Auburn, Cambridge Independent Practice Association, with HIPAA. This is in addition to likely continuing their existing contracting relationships. Currently BIDCO contracts on behalf of Cambridge Health Alliance, Orange General Hospital. It's stated an intention to contract on behalf of Metro West. We haven't received evidence that those are likely to end as part of this. So the contracting network that would result could potentially be larger than even the corporate system we're talking about.
So an important distinction here, Cambridge Health Alliance, Orange General, they will not be fully owned corporate members of NewCo. But they have been working through BIDCO to contract with payers. And we anticipate that that will continue to occur, even if they will not be owned by the new system.
Exactly.
Have the parties indicated to you why they wish to do it this way?
We have asked for a great deal of information about exactly how they've decided to set up this structure, how they've decided kind of to include and not include. I'll also note one thing I failed to mention. So McKiPA, they're planning to contract directly with McKiPA. McKiPA also has a role in kind of crafting what this new clinically integrated network that they're creating will look like.
Like, you've asked about it, but we don't have an answer yet.
It is likely in the materials that we have received recently, and that would be confidential, so we can chat about it offline. So the next few slides give background on each of these parties. So the first major entity joining the new corporate system would be Beth Israel Deaconess System, which, as you know, is anchored by Beth Israel Deaconess Medical Center. It includes 3 community hospitals in Needham, Plymouth, and Milton, as well as 417 employed physicians. I'll note that Harvard Medical Faculty physicians, which is kind of the bulk of the physicians that practice at Beth Israel Deaconess Medical Center, they are actually not a corporate part of the BI system. And so it's an important distinction to note that they are actually not part of this corporate merger. They too, we anticipate, will continue to have a very close relationship with these entities.
So there's a group of physicians that are at the Beth Israel that are not part of the Harvard.
They are the Harvard Medical Faculty physicians, HMFP.
I know that, but
Yes.
this other number, this 400, they are not part of that?
Correct, those are separate employed physicians by the BI system. Those tend to be community physicians.
Yes, I think that's what I,
Yes.
I got it. I missed it. But the Harvard doctors, they don't have a one Harvard, because the Harvard doctors are partners and they're not, you're in Harvard and others as well.
So there's a distinction between having a Harvard affiliation for kind of, affiliated with Harvard Medical School
But I'm
versus
just saying, in
this
terms of
corporate
contracting
entity.
with the payers, is there a Harvard type that contracts independently for all of the Harvard doctors, independent of which hospital? I don't think that.
No. No, so the Harvard
I just wanna
Medical,
make sure I understand
yes,
that.
absolutely. So
The Harvard medical doctors at the BI contract with, in sort of concert with the BI.
That's-
correct, they contract through BidCo. And so they're called Harvard Medical Faculty Physicians. However, there are other physicians, for example, in the Partners Network, who may have affiliations with Harvard Medical School that are not part of HMFP. So BidCo, as we've discussed a number of times in the past, has grown very rapidly in the last few years. So the contracting network now includes 9 hospitals and more than 2,500 physicians as of our last count, including 2 of the hospital systems, as we've discussed, that will be joining NUCO corporately, including the Baptist and Hannah James Hospital.
And again, the one thing I would highlight here is there are entities that are part of BidCo that are not joining the corporate NUCO system. And that is something that we have asked about, both to the NUCO parties, how do they expect these relationships to change over time, as well as the individual parties who are not going to be part of the new corporate NUCO system. How do they think that their relationship with BidCo and contracting is going to change over time? So we're asking both sides of that equation what their impact projections are going to be moving forward.
Yeah, now you may be getting to this, so you don't have to answer right now. So when we talk about partners itself has negotiating agreements with the payers, but they separate their both their hospitals and their physicians into different categories, sort of in-city, academic, and, the middle line and community and stuff like that. So when we get to BidCo, if you, again, as I said, you don't have the answer right now, you can go into it, how BidCo has operated and how they plan. So for example, will the Harvard, say the Harvard Teaching Hospital become part of BidCo or are part of BidCo? How do they compare? Is there any distinction between them and say the other Beth Israel factors? I think that's an important issue whether there is complete equality, so we talk about BitGo, it's one unit, or they too have some degree.
Being covered with how big it works.
Yeah, exactly. So, some of this is laid out actually in our past CMIR, when we went over the Baptist and the Metro West. So, so the way that BidCo has operated has been to have one, kind of physician contracting structure. And so their physicians get the same rate from payers, whether those physicians are in the community or at the academic medical center. Unlike what we've seen with other providers, they don't seem to have the same kind of, all of their community hospitals get like a very similar rate. So the hospitals tend to be actually different from each other. And so there doesn't seem to be that same, you know, all of their community hospitals are paid in this exact
Yeah,
same
I
rate.
know that they claim that, because I think this becomes increasingly important as their organization builds out around. So if I hear you correct, when it comes to the physician, there seems to be one rate, whether they're a community-based physician or a Harvard teaching hospital, a Harvard faculty. But with respect to the hospitals, each of the hospitals that have traditionally been part of BID, at least, they have different rates depending on what past circumstances, right?
Right.
I think one distinction I would make here, and I think this will be part of our review, is do we see a difference in the data and the information about the BI-owned hospitals, so Needham, Milton, and Plymouth, versus the contracting hospitals, so Lawrence General, Cambridge. And do we see differences both in terms of what their rates may be, but also in terms of their ability to redirect care to those different institutions? And you know, we have seen in past transactional work that there is a difference between a full corporate ownership and just a contracting relationship. With a full corporate ownership, that entity benefits fully from all of the revenue that is generated from all of its different component pieces. On a contracting basis, it may not, if they're successful in redirecting care through one of their contracting affiliates, they may not benefit in the same way from the revenue that's generated. So one of the things that we're going to be testing and looking at is over the history of Beth Israel and BidCo, do we see any differences in terms of the experience between the contracting relationships and the corporate relationships, and what might that tell us about what we think will happen with, say, Anna Jakes, who is now going to be joining and becoming a full corporate affiliate for UCO moving forward.
And what happens to Cambridge Health Alliance, Lawrence General, and Metro West Medical Center that are part of BidCo but are not part of BidCo? So just to reiterate what the chair said, is interested in the NewCo system as I am in the changes in the operating model of BidCo.
And just to sort of lay out the complete picture, we've talked a fair amount about BidCo. We know less about Lahey and its, whether it has any distinguishing characteristics. And again, we don't have to answer it now, but at some point, how does Lahey behave and how will it behave? And will there be, like we've seen in other transactions where there's an automatic increase by moving from category A to B or B to A. So we need to understand that.
Yeah, and I would just note there, Lahey also has a contracting network, so they do contract on behalf of some organizations that are not corporately owned. Correct me if I'm wrong, they're mainly physician organizations. They're not separate hospitals. And we have seen and reviewed Winchester Hospital, which was an independent community hospital, become a full corporate member of Lahey. So that will be another thing that we're going to look at the experience.
And also the physician within those.
Exactly.
Absolutely, and I think it highlights, these are two very different systems in many ways, and so I think, a lot of what we are trying to tease out is also how they're going to just integrate their cultures into very different kind of corporate structures.
Yeah, because this becomes very important. When we look to the end of the research and the report, there is things that would automatically happen simply by the change in ownership or contracting affiliation. and things that could happen based on increased market power. And of course, you know, one is easy to say, it either is gonna happen or not. The other one is based on what we know about research in other areas, so they're very different. So, the first one that I'm focusing on are these restructured contracting relationships, which may move people around, you know, that generate higher spending simply by moving from category B to category A. That's why I'm headed.
So this might be a sub part of it. I think we also need to look at the Harvard Medical School is not a conglomerate, and actually the residency training programs and the like are actually associated with particular academic medical centers. I'm not making any big statement in terms of the assumptions at the moment, but I would be wondering if that in fact is a factor in some of these relationships. Fair point.
So we highlighted up top that one of the other major pieces of this is Seacoast Regional Health System, which is the corporate parent of Anna Jake's Hospital. So Anna Jake's is a 140-bed hospital in Newburyport, so kind of the very northeast tip of Massachusetts on the New Hampshire border. It also includes a small physician practice, 35 physicians or so, Seacoast affiliated group practice. Both Anna Jake's and those physicians already contract through the BidCo network. So as David highlighted, one of the key things here will be what does it mean to move from being a contracting affiliate of BidCo to being a corporate member of this ecosystem.
Are we looking at the underlying finances of these organizations as well?
Yes.
So independent of the merger, what their future may hold?
Yes, so we work with a team of accountants and we have their audited financials going back a number of years.
Are they providing opinions other than just looking at historicals? Are they guiding the HPC in terms of analyzing the financials and the combined projections?
So, yes, so we do ask for projections and then.
And the accounts analyze those projections and they provide you with the important detail on that? And you'll be sharing that with the commission members?
Yes, so as part of our reviews, what we do is we obviously share the materials with contracted experts, both kind of projections as well as historic information. We also have the ability to engage in ongoing conversations with parties, and so a lot of our process takes place over months because we're doing back and forth, making sure that we're understanding everything rigorously, and so some of this may also be teased out over the coming months.
And would just, you know, emphasize again, obviously this is an incredibly important transaction, and part of our expert base here is you, our commissioners and board. So you do, as a member of this board, can look at the confidential information, and we do expect to have a high level of interaction with each of you as we continue this transaction moving forward.
So the next major corporate piece of this is the New England Baptist Hospital, which, as you know, we did a market impact review when it joined BidCo. It is an orthopedic specialty hospital. It has a close clinical affiliation with the IDMC as well. 3 outpatient facilities in Brookline, Chestnut Hill, and Dedham, and about 100 physicians. We've included service area here just to show, like most of our specialty hospitals in the state, it has a very large service area. You know, so again, this raises the same type of issue that Anna Jake's does, where what does it mean to move from being a contracting affiliate to a full corporate part of this system.
And the one additional wrinkle I would just note here is this is a specialty hospital becoming a corporate member of a system, and we just went through a process of examining that with Mass Ioneer, and there are some interesting questions that are raised when we talk about specialty hospitals and access to specialty services.
And the 106 physicians at New England Baptist are employed physicians. So kind of one of the things I've been trying to wrap my brains around is what type and Mount Auburn, and the fact that some of those positions are owned and some are contracted and some are in an IPA. It breaks my brain to think about how that part is going to work. But if we could at some point circle back and talk about what's happening to the employed physicians versus the contracting physicians for these entities. David, we're gonna have like an 8-page matrix here so that we can understand what this means, I mean, really culturally, but organizationally and structurally. So, I mean, a question is, do these employed physicians stay as employed physicians, or do they move in some way into a new imaginary physician group that's going to be contracting with someone?
I mean, I think at this point, and obviously our understanding is still evolving, at this point, our understanding is that the NUCO system is going to become the corporate member of each of these organizations. And so their subsidiary parts that are kind of corporately owned, employed, et cetera, are all envisioned to become part of that corporate structure. Now, obviously, there are going to be decisions being made at the local level within some groups. So there could be groups that decide to change their relationship as part of this. But the vision is that it's kind of at the very top level that the corporate member is changing. And so the subsidiary parts themselves aren't envisioned to change at this point.
To your point, Commissioner, around kind of that 8-page matrix, we've thought about kind of the Venn diagrams of all of these different things and quickly landed into 5-dimensional Venn diagrams. So we'll continue to evolve how we can think about the different slices and different types of relationships.
So at last count, BIDCO has 9 hospital members, about 2,500 physician members. Obviously, these numbers are subject to change. We're running them all down. We do understand from recently provided information, for example, that Charles River Medical Associates is no longer part of the BIDCO network.
We'd also highlight here there are a number of community health centers that are affiliated with these organizations as well.
So this is the same map that we showed last time. So these are the general acute care hospital service areas for the entire BIDCO system. So it excludes New England Baptist, which, as we said, obviously has a specialty hospital and has a huge service area. So you see in red that these are the current BI-DMC owned hospitals. Those are their service areas. The orange is Anna Jake's, and so that would become kind of part of this red owned area. And then the yellow areas are BIDCO affiliates, so Orange General, CHA, Metro West, that are not proposed to be part of this corporate system, but which could be contracting through BIDCO or through NUCO rather in the future. So the Lahey system, the next major corporate component of the proposed NUCO system, has about 1,000 physicians and 3 hospitals serving northeastern Massachusetts, including their medical center in Burlington, as well as its Peabody campus. Northeast Hospital, which includes Beverly and Addison Gilbert hospitals, as well as Bay Ridge Hospital, which provides psychiatric services, as well as Winchester Hospital. And then these tables just summarize again, as of our latest count, the hospital members and physician group members of the Lahey system. Finally, the last corporate component of the proposed NUCO system would be Mount Auburn Hospital in Cambridge, which currently contracts independently. So as we noted up top, part of Care Group, it does have an affiliation with BI-DMC through that, but it is not contracted through BIDCO in the past. McKipa, which currently contracts independently on behalf of Mount Auburn physicians as well as other physicians in the Cambridge area, would begin contracting through NUCO as part of this transaction. It would not be corporately owned. And so in total, this map shows the general acute care primary service areas of all of the hospitals that would be part of the NUCO system. So we are looking at a large swath of eastern Massachusetts. This is obviously within our service methodology. My recollection is that in the public materials that the parties have provided to the DON program, they've estimated that there are around 4.9 million people living in the service areas of the code system. So a very sizable chunk of Massachusetts.
How does the map look if you overlay partners on that?
Off the top of my head, obviously, Partners is also most of eastern Massachusetts. They also obviously have Lee Dickinson Hospital, which is in more of the central area, or west.
Hello, go
Yeah,
ahead.
Sorry. In terms of their eastern Massachusetts service area, it would not be very dissimilar. So some high-level notes about the transaction. So the parties state that their goal is to create a new comprehensive and distributed high-value healthcare delivery system in eastern Massachusetts with the highest quality of care and lower costs. For the corporate piece of this, the parties are envisioning administrative and clinical oversight at a system level and a board with fiduciary control over all component pieces. But there would also be local hospital boards and management of day-to-day operations at the local level. The parties claim that this will not only allow them to do some consolidation of administrative functions that will allow them to achieve some savings, but also get better debt financing.
There's been a fair amount of new research done about systems. So you have to make an unbelievably complicated system somewhat simple. So you have two fundamental arguments. Again, I'm simplifying. On the one side, you have the argument is that if you take all these different components and you manage them efficiently, you might change significantly what services are provided where. So, we have some systems that are saying, okay, maternity, go there. Psychiatric, you go there. Inpatients, surgery, go there. Orthopedics, go there. You move things around within a big system in a more efficient way. So that brings about efficiency. There's recently been an article arguing that, but what happens is you lose local control, and particularly when they're over a big area. So what used to be the local comprehensive hospital becomes one or two services. So the good news is you can generate a lot of efficiencies, if not savings, doing it that way. The negative of it is that you really fundamentally begin to change the nature of the delivery system in each area. So that's one argument. The other argument is you leave things alone, you become a gigantic bargaining agent with this, and you use your power to bargain, A, with payers, but B, with suppliers and other things, and you extract savings, if not more, on the one side, with lower costs of buying, but you also extract higher payments by bargaining. And ultimately you get this, I wouldn't say clash, but you get this complicated set of dynamics going on where there are pluses and minuses for both. And of course, as we begin to orchestrate this discussion, we're going to have to sort out those two forces and the relative advantages, right? Is that the way you're thinking about it?
Yes, that's a great summary.
Yeah, and I would add to that, we are absolutely asking about, and have asked, what do they envision in terms of the rationalization or redistribution of services such that you're creating the most efficient? Does every hospital need to have this service line or this particular type of high cost setting. But we also recognize that some of this will take some time for the new system to develop, and that some of that is based on local input. One person's rationalization is another person's loss of important resources in a community. And so I think this will be a point that, as we go into this analysis and investigation, we're going to have to test exactly that tension point that you're raising.
Have the parties provided estimates of the quantitative estimates of the administrative savings?
We have received a number of quantitative estimates. We can kind of speak with you in more detail about that offline.
I mean, I'm sort of curious, but that's going to be my question on all of this, which is I'd kind of like to know what quantitatively the parties think will be the impact. You know, will we say 5-year 5% on the administrative budget, and save the Commonwealth an additional 4% because patients were moved from others to us. I want to get a sense for what the parties believe the impact would be quantitatively, not just qualitatively.
And just to be clear, because this is not confidential, we asked for that very explicitly in our information requests and areas that we were required to respond. So the parties also claim that the transaction will create a system that will be a more competitive market in Massachusetts. So highlighting some of the market dysfunction that the HPC and others have noted in past work. The parties claim that this transaction will allow them to attract care away from higher price systems. That in and of itself will exert price pressure on other providers in the market. That it will enable them to keep more care in the community, and that it will allow for new innovative insurance products to be marketed. They also claim that this will allow them to invest in systems that will enable them to assume increased responsibility for health outcomes under BPM contracts, that they'll be able to join, they'll be able to share best practices among all of the already high quality providers that will be joining this new system. And they state a goal to expand access to services, including behavioral health and primary care services. They also are very clear that they believe that these goals necessitate this full corporate merger that's being proposed. So we'll skip over these next few slides. I think we've already kind of given you the update on where we are in the process. The only thing I do want to note is that we have sent information requests to other providers as well as payers in the market, and so are anticipating data and documents from other parties, other market participants as well. So,
Okay, just a quick question. We've been talking generically about the parties and asking the parties for information. Can you just break out how that process is working? Is there kind of one point person for the corporate, one point person for the contracting, one point person for every entity? How is the information coming into us?
sure, and so we in our CMIRs have generally been flexible with how parties provide us information. And so we sent information requests to each of these entities that we laid out in these slides separately. They have been working together, and many of their responses were provided jointly. And so there is some information that is, financial information about one party where they provided it on their own, but much of this has been provided in 1,000+ page documents, all from all of them combined.
Thank you.
So jumping ahead to slide 30, I believe, I did want to just show some early results from some of our analyses. So some of these I even mentioned very briefly in the December board meeting. So here I just wanted to give you a sense of the statewide market shares that we're looking at across different cuts of services. So here we're looking just statewide. Obviously, in any given service area, we could be looking at far more concentrated services, but this just gives you a sense of what the statewide market would look like. So looking at the inpatient side, you see that using 2016 discharge data. The partner system accounts for about 27% of statewide discharges. The parties that are proposing to come together here are 24.7%. So they would be a close second, and you see in parentheses each of their shares individually now. And so we would be moving from a system that has a partners at 27% and their next closest competitor at 14% to a system where partners is at 27 and the number 2 NUCO system would be at 24.7. And then everybody else would be, then the jump down is pretty dramatic, down to 7% for UMass. We see that it's even tighter kind of number 1 and 2 in the outpatient market. And so this is not just things on kind of general acute care hospital campuses, but also outpatient campuses out in the community. And so here we see that the parties combined would have a 26% of the outpatient visits using 2014 data, which is the latest APCD data that we can use for this, and partners would have about 26.7, with everybody else again at a much lower.
From your past experience, as you see these acquisitions take place, do the market shares typically increase, remain the same? How does that typically work from what you've seen?
So we have seen that generally when we have done our past CMIRs and kind of added up what the market shares are kind of going into the transaction, we've seen that has kind of pretty closely mirrored what has actually happened.
So it is moving, and all of these market transactions are moving in the direction of more consolidation, right? So where we have seen these transactions, they are increasingly taking a portion of the share of services. We have not reviewed a transaction to the scale of this increase.
Just a quick question. Thanks, all. It's really helpful. Clearly, a lot of questions to be answered, and a lot more information to share. I appreciate that. I'm just wondering, when it comes to NUCO, what would their total Medicaid population percent be of their total book of business?
That is a fantastic question. So that is an analysis that we are doing. I do not have an answer for you at this time. The primary care market, we see again, partners would remain the market leader with 15.8% of primary care visits in the state, but this combined entity would be projected to account for 14.1%. So again, a relatively close second to the partner system. Pause there for any more questions.
So a couple things that I think are worth looking at here. One is a lot of these entities have been before us in the past and have made commitments regarding some either at contracting or merger level. So to the extent we could look backward and see what follow-up has been to those commitments to get a sense of at least where we're headed in the future. The second, both Lahey and BI-Lahey have been really leaders in the behavioral health side of things, and it's a major part of each of their book of business. And so some analysis of what this means regarding those services, I think, will also be important. And as we look at the market concentration here, I think there's a premise, and I think it was stated earlier, that somehow a strong number 2 mitigates number 1. Having just rented from Hertz, I can tell you that doesn't actually work. But David once told me we can't compare rental cars to healthcare. But I'm sort of curious about that in terms of other markets. And if we're looking outside of Massachusetts, what that experience has been and what we should take from that if that data were to be available.
Thank you.
Any other thoughts or
No, I agree with what was stated before. It's also just the one thing that jumped out at me where it said attract patients away from higher priced providers. I'm wondering if the opposite could be true, or it's attracting patients from lower cost value providers to go to this new system, what that impact could be. But I think we had to reverse that issue as well.
Just, if I could just interject on the issue of what we know about this in general. The economics literature actually does not know very much at all about what happens when you have a dominant number one system and then a second system that gets to be very large in comparison to the number two system. The literature is quite clear about what happens, and I'm not talking just in healthcare, just the literature is quite clear about what happens when you have a dominant number one system that gets bigger. But as to whether having a dominant number one system with a number of smaller competitors, or a dominant number one system with one system about as large, as a company about as large as a little smaller and so on, there's actually almost no literature on this. So we're not going to be in a position where existing body of evidence is going to strongly suggest one thing or another.
Unfortunately true. Yeah, we had an interesting, if you remember back to our hearings, and Professor Dabney, we asked her that question. And we didn't, I mean, she gave us the right answer, which wasn't the answer we wanted to hear.
She gave us an answer.
She was very good at dancing, I recall.
All right, well, seeing no other comments or questions at this time, I think we can move on from this, but expect to continue to be heavily engaged with you as this moves forward, excited to share more information as we receive it and add analyses that we're going to do, and look forward to continuing engagement. Thank you for the feedback and guidance today. So moving on to our next agenda item, wanted to return to our 2017 cost trends report. We did spend a fair amount of time at the December meeting going through many of the major findings in our cost trends report. We did have to stop the presentation in the interest of time with that particular meeting. So want to come back, and I'm joined by Dr. David Auerbach and Sarah Sadownik from the cost trends team, just to finish off the findings that were presented about in the cost trends report, and then shift to a conversation about the policy recommendations that the board is interested in including in the final version of the cost trends report. And I would just, again, emphasize for the board, we are interested in your feedback and input. The report has not been finalized as of today, and we're hoping to be able to incorporate whatever guidance or suggestions you may have for a final report, which will be released in February. So your feedback is most welcome. On slide 35, I've shown this slide before. It's just a little bit of detail around the revised approach that we took this year to the cost trends report. As you may have noticed, it is not quite the same length and depth as previous cost trends reports, which sometimes exceeded over 100 pages. We went a little bit more focused this year, and then supplemented that written report with a chart pack. And the chart pack provides updated data and graphs and charts on really important topics that we've continuously examined. Things like readmissions, ED utilization rates, uptake of alternative payment methodologies. And rather than wrapping that all up into a written report, we have a more easily accessible chart pack where people can grab the graphs that they're most interested in, but continue to update these important areas that this commission has put a priority on. So with that, I'm actually going to turn it over to David, who's going to talk through two topics for us today. One is a new analysis that we did looking at performance variation of provider organizations in Massachusetts, and then we'll talk a little bit about alternative payment methodology, uptake, and uptake in tiered and limited network products, and then move to the policy recommendations.
Okay, so I'm happy to have a chance to talk through the rest of the cost trends report highlights. So this section is describing performance variation among provider organizations. This is building on what we started last year, where In previous reports, we had focused on provider variation mainly in hospitals. We looked at maternity variation spending and if any in other areas like that. And we wanted to take a step back and go to the larger physician organizations that are referring patients to hospitals, that are managing their care, that are responsible for APMs and coordinating care. So to do that, it's more complicated. You've got to be able to track a patient everywhere they go in the healthcare system. And fortunately, we have the APCD. We can follow patients. And the harder part is to link those patients to their PCPs and to the organizations that those PCPs are in. So we were able to accomplish that, and I'll describe it a little bit on the next slide, with the combined forces of the APCD and the RPO data. And this is pretty unique. You can't do this anywhere else in the country. But these data sets, I'll show how they work together. And once we have that, with the full richness of the APCD data, we can look at organizations and compare them on any number of things, such as spending by category of service, potentially avoidable utilization, referral patterns, and really you name it. So we're just showing some of the beginning of this line of research here. So the way this works, you have patients in the APCD, and to note, our extract of the APCD that we work with right now has just Blue Cross, Tufts, and Harvard Pilgrim patients. So think of those in 2015 for the full year of everything that happens to these patients. What we do is we start on that bottom level with those folks we can identify. We then find out who their primary care providers are. In some cases, the payers have told us, especially if you're an HMO, you know who that is, you're assigned someone. For the PPO, it's more difficult. We use modeling to attribute who their most frequently seen primary care provider is, the same way that Medicare does it for ACOs. And then in the RPO data, they tell us who their PCPs are, so we can connect those patients ultimately to the provider organization at the top that they belong to. So in 2015, we were able to do this with about 1.4 million adult patients. And you see on the right, a few end up getting left out of this. Some patients, their PCP is in a group that's too small to report into RPO, so we don't really know who they go to. And there's a few patients who don't have enough claims. We can't actually find out who their PCP is in the data. So those are left to the side, and we'll show some results for the 1.4 million, which is about 1/4 of the full population of the state in the next series of slides. And I'll just say that much more of this is going to be available in the full chapter of the cost trends report, and we're going to make it available online. Some of it through a data points release at the end of this month, where users can go in and find the organization they want, and interact with the data, and dive deeper if they want. So first we have the organizations listed here on the left, and a few of the interesting patient characteristics and how they vary across the top. One of the most important things is the risk score. You can see the average risk of their patient bases. It varies from about 0.8 to about 1.1. That's with a 1.0 average in the state. So we're going to be controlling for patient risk through everything we show you. That's important to make sure we're comparing like patients across systems.
From this, we're to conclude that BMC is very bad at coding.
It's a good question. BMC is kind of funny in this data. We tend to think of it as, in a high need area that they would have to. But the patients who have commercial insurance with BMC physicians are in fact on the young side. For whatever reason, I don't fully know why, but you can see that 90% of them are over 55. They have the youngest patient base, and they tend to have the lowest risk. So maybe they're also bad at coding.
Maybe they pick low cost plans.
And again,
It's possible.
commercial patients. So when we think about BMC, this is a smaller proportion of their overall.
Which does include Medicaid and Medicare.
Does not.
These are just their commercials. That's right. They have a high payer mix of public payers.
Look at South Coast. Here.
South Coast has the highest risk patients, and their patients are from the lowest income areas, as you can see in that.
Straight commercial, doesn't include.
This is just commercial. Yeah. Okay. We also add in some interesting variables that we link to your zip code. This one called the Area Deprivation Index, which uses housing and economic and employment data from the area to measure the degree of how disadvantaged an area is, and we'll control for that in some of the later studies too. You can see the type of patients are in the least
What
disadvantaged. Yeah,
data are you using from APCD 2015?
this is from 15. fresh off the press. We presented some of this in the December meeting, but that was the 2014 data committee. Okay. All right, let's move into some of the results. So here the top line number, you have total spending by these patients for the full year. And you can see, in addition to ranking them by total spending, there's a lot of variation here, 32% from top to bottom. That's about $1,500, meaning that basically a patient with a partner's PCP who looks similar to a patient with a Reliant PCP will have about $1,500 more spending over the course of the year. We've coded these organizations by their structural type, whether they're anchored by an AMC or physician-led, just to highlight some of the patterns that we do tend to see in the data. And they're pretty evident there. This pattern is seen throughout in this spending. So that's the top line spending number. We wanted to then understand some more of what's underneath.
Adjusted
Yes.
items are on
And this is risk adjusted.
that's important.
Yeah.
Given what you just saw.
Okay, absolutely. Yeah. So then we broke down that spending by four categories.
Just as a matter of course, I would still ask you most of these when you risk adjusting.
We put a flag, an orange flag that I would say serves as that you see at the top of the chart there. That's what that's trying to do.
Risk adjusted.
Yep.
That's the way it is.
That's it.
Okay. That's, I'll know what to do.
Yeah, we'll keep it down. Okay. So on this slide, some interesting differences in the category of spending. You can see right away that the hospital outpatient spending varies the most across these organizations, about 2 to 1. Those dots are scattered much farther than inpatient care, for example, is much more clustered, similar amounts of spending across these orgs. And you do see the orange circles at the low end of that hospital outpatient spending. So the physician-led groups are spending much less in the hospital outpatient department. And I'll show that again on the next slide. And you see pharmacy spending and professional spending is a higher portion of the total, although less variation there. So we really wanted to focus in on that hospital outpatient and understand that better. And we showed some results from that in December, because that's the second chapter of the cost trends report. Okay. So here we're just showing the groupings by those organizational type, highlighting again that inpatient spending varies by about $100 per patient per year by type of provider organization. The outpatient spending varies 66% across these organizational types. And underneath that, you have price differences, you have utilization differences, you have shifts in site of care. These are all things we're trying to continue to untangle. Okay, I'll show one utilization slide. The utilization we wanted to be even more careful with. You can see the orange, the yellow flag up there, risk and demographic adjusted. We adjusted here for not just the patient health risk, but patient age, gender, area deprivation index of their zip code, income of their zip code, payer, and whether they're in a self-insured or fully insured plan. So a wider array of things. And even then, there are factors that we can't control for that are underlying some of these differences, but we see a 2 to 1 difference by organization in the number of avoidable ED visits per 100 patients. You can see the variation there. And avoidable hospital visits, similar, about a 2 to 1 variation from top to bottom. So significant. And we are continuing again to try to understand what's driving this. We've looked in the past at primary care access to after hours care, care coordination. Some of these factors are probably in there, but we don't know them all at this point.
Mary Lou, I think you can answer this the best. If you were to just take, say, the Medicaid population and look at these same issues relative to the different delivery systems. So the issue is how much of the variation is the type of patients they're dealing with, and how much is what the delivery system itself is doing. Yeah. Do we have any data like that? Have you ever seen data?
Well, we have seen some data. Actually, Marty and I were just talking about how surprised we were by the BMC, since this is the, I actually expect that on the Medicaid side
Yeah.
more than on the commercial side. So, I mean, it's just sort of odd.
back.
When you go back to the other numbers.
Because I mean, yeah, because David mentioned there were things that the delivery system would do, but some delivery systems are facing much tougher sort of problems.
What I can tell you, Stuart, is as we are mapping individuals in the Medicaid program into the new ACOs, so how many individuals in the Medicaid program actually don't have a PCP.
That's what I was thinking.
Or perhaps had a PCP in name, like on a panel, but if you were to actually ask a Medicaid member, they wouldn't have a PCP. So, so we are actually hoping to see a decrease on the Medicaid side in what is avoidably similar to in the new ACO. But I'm a little surprised. We do actually have some data I think I can show around the ED usage, particularly on behavioral health. Yeah. But I was pretty surprised by the BMC. I almost wonder if it's like a coding thing. But I'm sure it's
Yeah.
not.
We did talk to them, we also were, we know that, it's hard to miss, we talked. They said that they weren't too surprised, they said, it's something they're working on. Their Medicaid rates were not that far from their commercial rates, it's interesting. Across the world, the Medicaid ED visits tend to be higher than the commercial, for BNC they were similar. And they thought maybe that it was something about access to care and just the way their culture of provision is, and they are seeking to improve that, so, but we don't.
No, well, let me be clear what I'm suggesting. That if you separated out the reason for this into two buckets, one bucket is the kind of patient that you're dealing with, and the other bucket is what the delivery system can do about it. Obviously, they're somewhat related, but to say, some delivery systems don't have to do anything. It's just the population they're dealing with knows what to do, and they're compliant, and they have a lot of. So the Lion can do nothing, and they're just going to look good in numbers. They didn't do anything, and BMC could do a lot and still look bad because they're facing a different. So what I was trying to do is take these numbers and like we risk adjust, but we're risk adjusting for the patients, not for who they are. And if you risk adjusted based on that, whether you would get, and so that's why I'm asking that.
Yeah, I agree, right, how much variation is due to the stuff that we haven't been able to control for, which is a lot. How much is left there? And, maybe it's half and half, but there are things we could probably learn from the literature as to how to portion out
Yeah, well, that's
that variation.
And I would note, this was our first time doing these type of analyses, and we were very careful, I think, not to ascribe judgment in terms of saying, someone's doing something wrong here, someone's doing something great here. We're not quite there yet in truly understanding this. Is it because even though we've adjusted for a whole host of demographic and health status variables here, is that risk adjustment truly robust enough to take account for some of the differences in patient population? Or is it something about what these organizations are doing? Or is it something about the context and the communities in which these organizations are serving? And those are all could impact these things. So I think part of what we hope to accomplish by even putting this out and making this public is to engage in these types of conversations. And so the conversation with EMC is one of those examples where, we put this out, we see this variation, and then we can start to have a conversation with the community about, well, what is driving this, and could we be more sophisticated in how we look at this, or do people need to, as BMC said, we know this is a problem and we're working on it, and so that can be a basis for action.
Last section, just a few more slides on APMs. Okay. So this is a slide we tend to show each year, and we have some good news on the commercial side. The left set of bars is showing the rate of APM uptake for the full commercial population of the state. We expected this to bump up this year, but it's up to 42% from 36% in 2015. And as you can see, when you divide that by HMO and PPO, it's entirely from the introduction of APMs into some of the PPO population, and that's mostly Blue Cross. So that 15% there is responsible for the entire rise. That's right.
We'll take complete credit.
We can take it. And so that might grow as some of the other payers are able to accomplish that in the future. You can see Medicare is pretty much holding steady, and then the mass health that's also going to grow as the ACO program develops in future years. So we wanted to learn more about what's underneath those commercial numbers, and you do see something interesting when you break them into groups. The next slide is showing the commercial insurers broken down into 3 groups. The Blue Cross, Tufts, and Harvard Pilgrim are in that top orange line. And you can see, as I just noted, that the PPO is responsible for a lot of the increase there, from 46 to 56%. That's the entire rise. You have in the orange line in the middle, other Massachusetts insurers. These are the smaller ones. You have Fallon and the NC HealthNet, Celticare, folks like that. They stayed at 36% in 2016, and they are a growing share. On the lower part of this table, I'm showing the market share of these 3 groups of insurers, and you can see that Blue Cross, Harvard Pilgrims, and Tufts dropped a bit from 67 to 63% of the market. These other mass insurers have grown, and their APM take-up has stayed flat. And then you have the national insurers at the bottom at 20%, who are really not using APMs to any appreciable extent. So that's really, you have several different stories underneath those APM numbers there, and different levers that you might be able to think about moving those numbers, but it's important to understand.
Do you have any, do you think theory as to why for the other Massachusetts insurers, they dropped from 40 to 36 from 14 to 15?
That's a good question. There could be member and compositional changes in their member bases that could explain that, but I haven't looked at it. But that's something we could look at. Okay. And I'll note those national insurers, they're mostly self-insured populations, and they're using the same sorts of methods they do for the rest of the country. Okay, and on this final slide, we've been tracking the uptake of tiered and limited network products in the state. Since GIC is such a big player here, we break it out with and without the GIC. So including the GIC in the left half, we see a small increase in tiered network uptake to 16% in 2016. Small increase in the limited networks. When you look outside of the GIC, everybody else, the tiered networks are really flat. They haven't moved at all, so it's entirely from increases in the GIC population, which is almost entirely tiered already. Small increase in the limited network, and then you see continued growth in high deductible plans on the top, up to 22% now, and there are more than half of small group insurance is in a high deductible plan at this point, which is a growing trend. That's a concern in terms of affordability. Okay. So that's the end of the main content. Here we have we showed this before, some of the key findings that you can take home and think about. Some of them are interesting. Noting family premiums we like to highlight every year, over $20,000 a year when you include cost sharing, which is a really huge number. And at the same time, our commercial growth has been lower than the US. And if we had grown at the US rate, we would have spent $6 billion more in our commercial market over the last 4 years combined. So noting slower growth, still high levels of costs, and other statistics around that. We also every year we include a dashboard of metrics. This was inspired by David Cutler, thank you, a couple years ago. And we also show performance against a few targets that we set through our recommendations process. Here's just showing those targets. A couple of green and a few are red. Growth in total health expenditures, we were below the benchmark, and that's really that top target that's green. You can see we're not appearing to meet our targets in the areas of readmissions, which we know about, and in our uptake of APMs in both HMO and PPO, below targets that we set a year or two ago. And another bright spot, as we showed last week, was in discharges to institutional post-acute care, which has been trending down. And if it keeps trending down at the current rate, we might actually hit that national average, which we set as a target for ourselves. So, one bright spot on the utilization side. Okay. All right. There are no other questions. Turn this back to Dave.
I do think we're gonna publish this. Two things, this is a great chart, but I would add, if we could, 2 components, not only the level of the change, and 2, where you can.
Wait, of what metric exactly?
Of, these 5 metrics. that
Yeah.
we have.
In the full dashboard we do.
Yeah, so that there's, in one place, it's great, some farm awkward,
Yeah.
But I think in some sense, the change is more important even than the level. The second is one of the things that is to benchmark us against the national. Because, you know, there's a whole bunch of things, some of which we do better and some of which we do worse. You know, in terms of the rate of growth, we're lower and so on, but we haven't distinguished ourselves when it comes to the emissions. So in other words, you know, I don't want to make it too complicated, but I think, you know, that those two lines would be important.
So I would actually point commissioners, in your binders, there's a tab that says the 2017 cost trends report. This is the draft of the report. And if you flip to that tab and then flip all the way to the end, which is pages 45, 46, and 47, you can see the full health system performance dashboard that we developed. And it actually, to your point, Mr. Chairman, includes a whole additional range of different metrics, compares our time trend in Massachusetts, also compares to the US, where there is, if there is a US comparison, and includes affordability, alternative payment methodologies, spending, utilization metrics, and so it is a much more comprehensive dashboard in that regard, and does do some of those US comparisons.
Yeah, because I know I've seen them in the past, but I was just referring to that one chart.
Yep.
So you have a sub-chart.
Yep.
But that's great. I mean, this is one.
And again, that dashboard will be published with the full report in February.
I appreciate the colors. My contribution to the colors.
So turning back into the slides, want to flip to page 54 in the slide deck and engage with this group on a conversation around policy recommendations. And interested in your feedback, your guidance, your additional input on this as we finalize the report and the policy recommendations. As you can see on slide 54, we have restructured our policy recommendations around two main priority policy goals of the Health Policy Commission. These track very closely to the two new committees that we've established, and roughly fall into kind of continued strengthening of market functioning and transparency, and secondly, continue to advance care delivery reform and payment reform in the delivery system. So I'm going to walk through what we're proposing as our recommendations this year, but again, want your feedback. I would note that many of these recommendations are renewed recommendations from previous cost trends report, especially from the last year's cost trends report, where we had a number of detailed recommendations. So we are renewing call in a number of different areas where there has not been the level of action and effort that we think is warranted. But also would highlight, and you'll see it in some of these orange little boxes, areas of new recommendations for 2017, so probably spend a little bit more time talking through those. So moving right into slide 55, the first main recommendation that we have in terms of strengthening market functioning and transparency is around pharmaceutical spending. We continue to see that pharmaceutical spending is a major driver of healthcare spending in the Commonwealth. It was the largest growth category of growth in the year that we examined, and continue to think this should be an area of focus moving forward. And so we have a number of sub-recommendations here. Would note that a number of other states have taken action and passed legislation that would increase the transparency of the prices, both in price increases for pharmaceutical drugs, but also for the launch prices of drugs when they're introduced into the market. I think there is continued space for the Commonwealth to continue to enhance its transparency of this important sector. I would also note that we do highlight that it should not just be pharmaceutical manufacturers, but pharmacy benefit managers are also an important component to spending in this sector, and some additional transparency there may be warranted. Secondarily, and we'll stop here for a second, we do have a new sub-recommendation around maximizing value in the Mass Health program. And here too would note that a number of other states have taken action to think about new strategies to be able to get the most value out of the pharmaceutical spending in the Medicaid programs. There are two ideas here that the governor has proposed as part of his annual budget process, which we think in this recommendation warrant support in terms of advancing these ideas moving forward. One would authorize the Secretary of Health and Human Services to be able to negotiate directly with pharmaceutical manufacturers, understand their price inputs and drivers, and to be able to maximize the ability for supplemental rebates attached to drugs in the pharmacy program. The second is a tool that is widely used in commercial plans and accepted in the market, which is around creating a closed formulary for pharmaceutical drugs. This would require a federal approval as all drugs that are approved by the FDA are meant to be covered by the Medicaid program. And here too, the governor has proposed a proposal which warrants close consideration and would note that, and I will defer to the secretary on this, but they have indicated a number of protections that would be put in place along with this policy around ensuring access to necessary medications.
If I may, I wouldn't call it a closed formulary per se. What it is it's a value-based purchasing arrangement of which only if we could not negotiate with the manufacturer would we then propose putting the drug on a closed formulary. I want to be clear, it's not a like a closed formulary. It's only for about less than 1% of the drugs, most of which are orphan drugs with very specific criteria, where we go through a public process around transparency or negotiate with the manufacturer directly. That if we could not do that, we would potentially put that on a closed formulary. We do propose changes, which does not require statutory changes, to change the composition of the drug utilization review, which is mandated by the federal government to include consumers on that, which has never been, to broaden that. And we would use a third party to help, like ICER, to help us actually determine fair prices. Anybody can go up onto the mass.gov Health and Human Services website and actually see the proposal. So all of our documents are up, both on the DHS website and on the Mass Health website. People will see what the proposal is. So thank you for that.
It's a really important distinction, and we'll make sure we're describing that correctly, because it really is a negotiating tool, and it's not necessarily the endpoint that we would seek to have a closed formulary, but it does provide additional leverage at the negotiating table in order to maximize the value for these drugs in the program. I won't walk through the other additional sub-recommendations here on the pharmacy side. These are repeats from previous cost trends reports. But continue to want to encourage the use of value-based benchmarks, such as what ICER puts together in both negotiations and in some of the contracts that payers and manufacturers are building together. It's not always about price here as well, and do think that there are opportunities on the utilization side of pharmaceuticals, and so continued work in terms of treatment protocols and guidelines about what is the most appropriate time and place to use specific types of drugs. And finally, continued provider education about what those low-cost, high-value opportunities may be in the pharmaceutical space. The second recommendation on this page is out-of-network billing. I will not go into detail here. This is a repeat from a recommendation last year. Again, many other states have taken action here to protect consumers and to protect the market, to create a stronger market that would allow for tiered and limited network products to potentially thrive. And again, call for action in a number of areas in out-of-network billing. So there continues to be, I think, a fair amount of conversation around out-of-network billing. We did have a presentation where we presented some data to this board at the October, I think, board meeting or committee meeting. The state Senate's version of their healthcare legislation did include some provisions around out-of-network billing. And this was a recommendation of the Provider Price Variation Commission that also filed its report after our report last year.
David, if I remember correctly, the discussion we had, which was the detailed discussion about the network, had some really good information. But I we did discuss the idea that it perhaps was a little heavy on the ambulance side and a little less heavy on some of the others. We were going to talk about if we could find any new information. I'd like, if it's, I don't know if you're planning on doing publishing for that. I just think the ambulance is in another category, these are the emergency department versus, you know, the anesthesia. So if there's any new information, it'd be great to have that.
This is a continued area of examination for us as we continue to evolve the data, and we expect to be back. And we have heard from some reactions to the presentation we made, I think in October, exactly to that point, that some additional nuance in terms of how we think about ambulance versus emergency services versus those services that may be provided by a provider in an in-network facility, but are out of network. Think your anesthesiology, your radiology, your labs. And so there is different dynamics in each of those areas that are worth being nuanced about. Agreed. On the next slide, I will move through this relatively quickly. These are, again, a few repeats here from past cost trends reports. Continue to highlight the provider price variation issue and unwarranted price variation. We had a big focus in this cost trends report around hospital outpatient spending and the very big differentials that exist between hospital outpatient spending and freestanding physician practices or other sites of care. A lot of this is driven by the additional facility fee component of the reimbursement to hospital outpatient departments. And again, here there have been proposals around limiting the continued expansion of hospital outpatient departments that can charge these higher amounts for the exact same services, for the exact same type of patients that are being provided at a much lower cost in a non-hospital outpatient department setting. And additionally, and the federal government has made some recommendations around this as well, for certain types of services like your standard doctor's office visit, an evaluation and management visit, should there be 100% differential between when you go to a physician's office versus a hospital outpatient department. And there are proposals to limit the upcharge associated with those services. Finally, on this slide, demand side incentives. We continue to want to strengthen the market functioning and think that encouraging employers to offer a choice of plans is a really important lever. We know that many employers only offer one plan to their employees, and where we have seen that employers can offer multiple different plan options, that they may choose to go into a limited or tiered network product, and that can provide value to the system, and would highlight that Connector has been extremely successful in creating a marketplace where, for the most part today, it's individuals. Individuals go to that marketplace and compare plans, switch plans during the open enrollments, and that has been providing an incredible amount of value to the Commonwealth. And so to the extent we can continue to be able to encourage, hopefully, employers to utilize the Connector as a way to offer different types of plans to their employees, we think that's a great tool. The last new thing I would note here is the Center for Health Information Analysis is launching a new quality and price comparison transparency website this year that will provide an opportunity for both individuals and employers. I think they are marketing this and thinking about this really around employers and individuals to go on and to be able to type in a type of service in their, a zip code, an area, and be able to see the differentials in price and quality across a range of services, and be able to help aid in their value-making decision. Typically, this information has been housed with the health plans to date, and members can go to the health plans transparency websites. This will be a public website that doesn't require a login, and that any individual can go to. And so I hope that both employers and employees and payers utilize that tool, and we'll see how that goes. But that is a new significant advancement in our transparency in 2018. And while not noted on this slide in the written text, there is a line around continuing to encourage CHIA to make publicly available all of the price information that they have in the interest of advancing our goal of being the #1 transparency state in the country. And so wherever we can get this transparency out, we think that that's worthwhile. So that is the 5 recommendations on kind of the market and transparency side. Moving now to the care delivery and payment reform side, we do have a few new recommendations here. So we'll spend a little bit of time on these. The first is really a reflection of an ongoing conversation that this commission has had, both dating back to last year's cost trends hearings when we had Lauren Taylor provide a presentation, and then this year where we had Dr. Karen Joy Maddox provide a presentation on readmission penalties, which is the continued emphasis on taking account of the socioeconomic environment of patients and accounting for that as we think about our healthcare system, and the fact that social determinants of health can have a huge impact on access, on patient outcomes, and on cost spending. And I really want to highlight, and it said here, that this is building off of leadership of the executive office and MassHealth, and MassHealth has really taken a leadership role in accounting for social determinants of health in their ACO program. We think that those efforts should continue to be expanded and replicated by other payers, including in the commercial space. So 3 specific areas: flexible funding to address health-related social needs. The MassHealth program, through the ACO program, does have some new allowances for flexible funding to be able to address housing instability and food insecurity for patients. We think that's a great innovation and should continue to be expanded even outside of the MassHealth program. The second is around accounting for these determinants when we do performance measurement. And so this really speaks to the last conversation we just had, which is around looking at the performance variation across those provider organizations. And as Chair Altman said, the patient populations are very different for some of these organizations. And it may not be enough to just adjust on the basis of health status, which we typically do in healthcare, to actually take into account some of the other social characteristics of these patients. And again, I would note, and this really came through in Dr. Karen Joy Maddox's presentation of the cost trends hearings, where the federal penalties on readmissions may have disadvantaged providers who care for a more vulnerable, low-income population by the way that those adjustments were made. And so let's continue to evolve our science in how we adjust for different patient populations. Again, MassHealth is piloting some of this work in their ACO contracting. And then finally, let's continue to build to the evidence base of what works, and I think there's a continued work there.
So, David, I personally am a very big believer in social determinism, but I do think, and I'm curious, when we talk about flexible funding, you know, we're dealing with 2 issues. One is add-on funding for social determinants, and you know, everyone that there's not a lot of negative consequences to the people that provide the service. There's of course negative consequences to the people who pay for the service. So you know, I mean, some add-on funding may be appropriate in public health and related stuff. The other is trade-offs between technically physical health and social determinants services, which is, I think, more than appropriately coming. But of course, in order to do that, you really need to change the payment system to allow the people that provide the service. So, I mean, it's not anything that you don't know, but I think how we write this is important.
Yeah, and I completely agree. And the written text, if you have feedback on that, I think where we have focused here is specifically in areas where some targeted flexible funding can lead to reductions in unnecessary utilization, where there is a direct connection to the healthcare system. And that is also a theory of change that we're testing through our new investment program, is that it's not just around kind of worthwhile investments in kind of infrastructure, but where we can see a direct linkage between unnecessary ED utilization, readmissions, behavioral health ED visits, and targeted flexible investments that if we make the right type of investment in getting that person into stable housing, and connecting them to the right types of services, we can actually see reductions on healthcare utilization spending. So that's where we try to be a little bit more focused than just social determinants generally.
But I think just to reiterate what Stuart said, making sure there's a section there that talks about tying into alternative payments. Because, I mean, Rishika's Pranandapool has a wonderful, passionate, data-driven presentation, but it's all capitated payments. So just making sure that we put the right context around this for our initial foray. Over time, we'll learn a lot more and can be more nuanced about it.
I just need to say this, which I realize is heresy and certain, but the evidence, this is unfortunate, but the evidence that is beginning to be developed, that what were considered truths about investment in prevention, wellness, and all these good things, that early diagnosis, that were going to lead to all this reductions in spending, just is not playing out. And the new research that's beginning to come online suggests you need to be careful. So I don't think we need to come to a conclusion, but I think we need, I think first of all, we need to emphasize alternative. There you can really see, when you put a provider in a situation where they stand to benefit, and we benefit in society, that's the win-win. Where you say, okay, if here's an alternative payment system, here's a more flexible source of dollars, make these investments, and you can see the benefits, and we can see the benefits. Just making the investments with the idea that somehow we're going to see at the end may work, but it may not. It may turn out to be an add-on. Just, just need, after all, we're in the business of doing both, trying to lower spending and trying to improve quality. And we don't want to be in a situation where what we do is add spending.
Thank you. The next new recommendation on this slide is around the healthcare workforce and engaging the healthcare workforce. This is, some of these sub-recommendations are not new, but have been kind of wrapped up into a new recommendation here. Really around kind of the evolving care model and ensuring that practitioners are able to provide care at the top of their license consistent with their training and education. So some sub-recommendations here include calls to examine scope of practice laws in the Commonwealth and to advance and to remove restrictions that are not evidence-based. And we particularly call out advanced practice registered nurses as one category, although there are others. We do and have talked about this in the past around establishing a new kind of mid-level dental health practitioner, specifically to expand access around oral health care, where we have issued research around oral health related emergency department visits in the Commonwealth. We think that providing greater access may reduce that unnecessary utilization. And then secondarily, continued support for new roles on the care team that are really focused on the needs of the community and the needs of specific patient populations. And these types of roles, and this is a non-exhaustive list, but wanted to highlight specifically community health workers, peer support specialists, recovery coaches. Our experience in the CHART program has been that successful teams that had team members like these roles were successful in reducing unnecessary utilization. And so again, thinking specifically about roles that have lived experience with substance use disorder or who come from that community and know the culture and environment of that community, we want to encourage and continue to support these roles on the care team. And then finally, I think a call for just engagement of the healthcare workforce in these efforts and hearing from frontline staff as new initiatives are being developed and implemented. So the next slide, one final new recommendation here, which again we've included in the past, although not quite in this form, is around we think a continued value in targeted investments to test and innovate in our healthcare delivery system. We have seen success both through the CHART program and the Healthcare Innovation Investment Program and other programs run by the state that funding and continued investment to advance our care delivery models is warranted and valuable. And we highlight three, again, non-exclusive, but three areas that may warrant continued attention. Pharmacological treatment in the primary care setting, telehealth and telemedicine, especially for behavioral health and for other services with low access, and mobile integrated health, which is using community paramedicine to be able to treat patients in their communities and potentially avoid unnecessary utilization. Would note, again, many of these initiatives are being driven by the Mass Health ACO program, and there'll be some funding associated with some of these through that program, but continue to think that continued investment may be warranted in these areas. And evaluate and prove the efficacy of these models. The last one on this slide is not a new one, so I won't go into depth, although it has now become, this is a major recommendation for this commission year over year. We continue to see that we have higher rates of utilization than our compatriots across the country across a number of important metrics: avoidable ED utilization, avoidable hospital readmissions, shifting care from community hospitals to AMCs and teaching hospitals, and in many cases, we're not seeing the type of progress that we had hoped for in these areas. So again, this continues to be a point of emphasis for the commission.
Do you know, since you point out that this is a recommendation we make year after year, and we're not seeing any change, I wonder if it would be interesting to try and think of how to construct a session during the cost trends hearings in October that where we took a different cut at it to try to understand why are we not getting any change in the face of such compelling data and such recalcitrant progress or lack thereof. It seems to me either we drop it as a recommendation because it's a useless recommendation, or we try to think of something very creative to do that can get people to think differently, so we get some traction on these issues.
Yeah, I'm open to suggestions on this one. The new investment program that we are out for procurement on right now does have avoidable utilization as its primary aim. So again, I think we're continuing to try to think of ways to invest in those right types of models, but this is a huge area of focus for the commission. Will continue to be a huge area of focus for the commission. I would note that the Mass Health program, the DISR program, has a number of these same metrics that they are also trying to seek improvement on. So the collective action, I think, is really important.
Yeah, but again, now there's a lot more research out there on why this is not happening. And it's not happening as recalcitrance necessarily or bad behavior. First of all, half of almost our insured population are self-insured. And so it's not the payers as much as it's the employers. The employers just, I'm sorry, they just are not willing to do the investment up front because they believe they're already paying for it. And the providers are saying, yeah, you might see savings over time, but I got to invest a lot up front, and I'm not willing to do it. So if you're in a voluntary environment on the provider side, and you're dealing with individual employers on the other side, what you've run into, it's not that I'm in favor of it. We either need to break that part, it's that part of it. There's a reason why this isn't growing. And by the way, we're better than the rest of the country by a long shot. Well, you look at that other chart where you're seeing almost nothing in terms of the rate of growth, in terms of alternative payment systems. We are way ahead of parts of the country as far. I'm talking about the alternative payments.
No, we're not talking, we're not there yet. We're throwing unnecessary utilization.
I know. I apologize.
Right, you're ahead of us, Stuart.
Sorry.
That's right, come back to
Well,
number
I
9.
thought that's the one we've been saying forever.
No, it's this one.
10 also,
It's-
but yeah.
Yeah, but before you get, yes, Stuart, before you get to 10,
I apologize.
no, you're just, as always, you're just 10 steps ahead from the rest of us. We're slower readers. Is,
I was so focused on this.
I didn't notice.
And I was annoyed about it because I wish we did that.
Well, I think some of us are perplexed, I'm not gonna use the word annoyed in my public hat. We've had number 9 as an item since the beginning. So, unlike my good friend to the right, I wouldn't suggest that we drop the recommendation, that we think of a different way of asking the questions and thinking about how to focusing on this a little more targeted at possibly at the cost transfer. What I would tell you is that, as David kindly said, in the ACO program for Mass Health, there are actually some very specific metrics measured. ED utilization, avoidable hospital admission, readmissions. It's really across 100,000 lives to the Medicaid program. And a very consistent collection of the information. So while we probably won't have good data for you in October, we could certainly a year from now, probably a year after March 1st, if we want to move on, certainly say what the data is starting to show us. And then I might say, can we drop that recommendation? No, I would never, because it's the right thing for us to push. So Stuart, about that, number 10. What was that again that you had no interest in?
Sorry, can I just
run.
So one possibility, just to build on Wendy and the Secretary's comments, maybe what we ought to do is sometime around Labor Day or so, release the most recent data by institution on rates of post-acute care use and so on. And then ask specific organizations to comment that are not doing well, ask them to explain their numbers at the cost trends hearing. We have asked folks to explain, but without a specific number, saying, look, why are you X and you're not Y? And we look all around and folks are at Y. So maybe we should sort of focus it a little bit more that way.
Yeah, I think that's a great suggestion. We did last year have a panel specifically around on readmissions and had some high performers and some lower performers. I think there's ways we can continue to be very targeted and specific in the types of questions we're asking.
Maybe, David, maybe this is something we could work on a little bit in the committee.
That's a good point.
And would note, we did organize these recommendations kind of around the committee structure, so that could be a continued conversation. So, Stuart, Mr. Chairman, sorry, to your number 10, this is also one of our greatest hits in terms of the continued adoption of alternative payment methodologies, which we continue to believe do provide an incentive for providers to do things like reduce unnecessary utilization, to steer patients to high-value care. We continue to hear from providers that they live in two worlds, a fee-for-service world and an alternative payment methodology world that creates conflicts when times are coming to make investments that will reduce utilization. That can have impacts on revenue. We heard this in the CHART program around the sustainability of some of those initiatives. So these are a lot of our greatest hits. Would specifically highlight we're continuing to call for increased adoption in the commercial market around PPO and self-insured, and this speaks, Mr. Chairman, exactly to what you were saying about the role of employers here. The one new sub-recommendation is that there has been a tremendous amount of work led by the Executive Office on quality alignment measurement in alternative payment methodologies, and hope that that work is adopted by commercial payers moving forward. The one bright spot I would note here is that we are expecting a significant increase in the amount of lives covered by alternative payment methodologies due to the launch of the Mass Health ACO program. So that cannot be understated in terms of a market changer, in terms of how many members will be a part of those new contracts moving forward. So open it up to any other ideas, thoughts, feedback on the policy recommendations from commissioners.
I'd like to say, really on number 7, I think it's really important that we've added the workforce. I know it's something that's played out in a lot of the plans and programs we've been talking about through this commission, and I just want to recognize, I think it's a really important piece in particular, not just looking at new care models and how we add the training for those new teams and care models and workforce, but also the engagement piece. I think that's really, really important. We're thinking about not just about the new jobs in the future and getting healthcare workers trained and prepared for those jobs in the future, but also how are we utilizing the frontline caregivers for engagement and the notion of reducing the overall cost of delivering healthcare. I think that's a very interesting perspective that not many people take a lot of time to sit down and talk to them about. When you do, I think we'll be amazed at some of the things that we can find out and learn about just by having a conversation and engage. So I think that's a really important piece of that, and so I appreciate that.
Thank you. So with this as a conclusion, I think next steps in the process is we have asked for further commissioner feedback up through next Monday. If you have feedback you'd like to give us on the text, on the recommendations, please do that. We then will redistribute the final cost trends report to all of you for final review, and then expect to release the final report in the mid-February time range, maybe around Valentine's Day, although not on Valentine's Day. So if you're comfortable with that process and where we are, would ask for consideration of a motion to move forward.
Yeah, but I think, at least I speak for myself, I do want to see the final written report. I think what we're voting on here is the level of recommendations, not the report itself.
I think the vote here would be to allow me to issue the report outside of the next, we don't have a regularly scheduled board meeting in February.
Usually, I understand in terms of timing, ultimately it makes a big difference how things are written. And usually you don't get approval of the report until you see the report. So I think what I'd like to do is approve the recommendation structure the way you laid out, then leave it up to individual, and if there's significant amount of concern as people read the report, that you need to bring it back. You can't, how things are written are as important as what is in those reports. See what I'm saying?
David, I understood you to say you were going to send the report out to each of us to be read. Did I misunderstand that?
But there's still outstanding comments.
Right. Right, and that you wanted the comments back by next week.
So yeah, I did send a draft around last Friday to commissioners interested in
Well,
continuing
that's what I
feedback.
want to hear, whether there's any concern about the written words, and whether there's going to be, there were a number of suggestions in terms of how the things are written, so I don't know whether that, what we saw was the final.
Actually, there are changes highlighted in the.
Yeah, I saw that, but what about the discussion we just had today? I mean, there were a number of, and they're making sure.
So can I just, my suggestion would be that you get all the comments, you incorporate the comments and comes back to the commission members and then finalize it next week.
So noting that the next meeting is on March 13th.
Is that what it is?
I'm missing something on why it's so critical to read around balance.
Is there some statutory?
Is it statutory?
There's no statutory requirement here.
I would say we finalize it, we take the formal vote the next board meeting, whatever that is, yeah. That would be my
Unless
recommendation.
you get for some reason. I mean, I think we're in fine shape. I just think that people should have. fine, we'll look at that again.
Final
based on this discussion, and then we'll just have a take a look.
That's great.
Everyone happy with that? So it was great.
All right, so we will table that motion for today. And in the interest of time, I will just cover the two quick program updates. And actually, these are pro forma program updates. I won't walk through these in detail. The one important new thing that I did want to mention, and I will jump directly to slide 75 in your slide decks, is since our last board meeting, we did issue certifications to accountable care organizations through our ACO certification program. You can see the 17 organizations that are listed here are certified ACOs. This does incorporate the entire universe of ACOs that are participating in the Mass Health program. So we're very pleased to take this step. I want to thank the organizations involved. Also want to thank the Mass Health team. This was really a collaborative process with them in terms of certifying these accountable care organizations. We're going to have a lot more to talk about in terms of what we learned about through the certification program, what are the next steps. Really the certification in some cases is just a little bit of a first step in this program. So expect to be back to the Care Delivery Transformation Committee and this full board as we talk about what's next for the ACO certification program. But a huge milestone in this program, many years in the making, and credit to many different people involved. So a huge step in our process for that particular program.
David, could you just explain what the difference between provisional and certified is in the ACO?
Sure. So there are some organizations that came together specifically brand new for the purposes of contracting with Mass Health. And so while we asked some questions in our certification program about how have you in the past organized yourself to care for different care populations or put in place some capabilities, they don't have a previous track record. And so the provisional certification does mean that we'll check back in, I think within a year, to say, they said we'll put in place these capabilities, we certified that, but we'll be doing a check back in. Again, organizations that came together specifically for the purposes of Mass Health. All right, so the final agenda item is the Executive Director's Report, and I have just one item to talk about today. This is the annual kickoff of our benchmark setting process. So again, to talk just about process, the benchmark is based on a projection of potential gross state product, PGSP. PGSP is an economic metric of the long run average growth rate of the Commonwealth, excluding certain fluctuations. This economic growth projection is set annually by the legislature and the governor as part of the consensus revenue process. And that creates the basis by which the HPC establishes the benchmark. And so this is an annual process, and it was completed earlier this month. As you can see on slide 79, the decision again was to set that long-term economic growth projection at 3.6%. That continues to be the number that has been used since Chapter 224 was passed, and is actually not surprising because this is really intended to be a long-run growth rate, and we would not expect a number of fluctuations from year to year in terms of long-term economic projections. The process by which this is done is the legislature, the administration, they meet with certain healthcare economists. They have external projections that are created by Moody's and by others, both nationally and locally, to examine economic growth as well as population growth in the Commonwealth. Needless to say, it is 3.6% again. So we then use that 3.6% to set the benchmark. And as we went through this process last year, between 2018 and 2022, the benchmark is set at PGSP minus 0.5% or 3.1% as the default. However, the commission may set that benchmark at some number between 3.1 and 3.6, pending a public hearing process and a vote, a 2/3 vote of the board. So the default is that it moves to 3.1 on a vote of the board. That is what we did last year. We went through, we had hearing, we heard from many different stakeholders. There was consensus that 3.1 was the target that we wanted to move to, and so that was the benchmark that we set last year. We're going to be doing that process again this year, and so again, we'll be planning a public hearing. We want to solicit testimony and feedback from market participants to help inform the board's decision about whether to stay at 3.1 or to perhaps move to something between 3.1 and 3.6. I've included here on slide 81 our performance against the benchmark in every year that we've measured it, and you can see over this period of time an average growth rate of about 3.55, although in the most immediate year it was 2.8% per capita growth. So at our next board meeting on Tuesday, March 13th, we'll plan to have a portion of our meeting time set aside for a public meeting, and we'll invite people to come testify before us. We'll be collecting written testimony as well.
Will we have any information, Charlie, on how we're doing relative to 3.1?
No, and in fact, we won't have information about how we're doing to 3.1 until basically September 2019.
That's what I'm saying.
The benchmark is set prospectively, so we set this into the future, and our analysis of past data is retrospective. So the benchmark that we would be setting this year is for 2019. So the benchmark we're setting is healthcare spending growth between calendar year 2018 and calendar year 2019. And we won't know how we did on that measure until calendar year 2021.
But there may be some preliminary estimates for 2017.
We won't have numbers relative to the period where we had the 3.1.
But we might have a guess about what it was in 17. Although typically that takes about a quarter to get a preliminary estimate. I don't know if years would have that. Yeah, but at some point, they would have a first guess as to how 2017 compared to 16.
So I think our plan for the next hearing and for this is to marshal all of the information that we have available to us, both locally in the state, nationally. What do we know about healthcare cost trends that can help inform this decision-making process? So we'll get as much information as we can.
I'm not asking you to make up numbers. I mean, I'm capable of doing that, but I'm not asking you to make them up. On the other hand, it was one thing to be, aggressive and moving the right thing at 3.1 this year. But the further you go out in time and you push in the system, the more it would be nice to know what you're doing. Okay, so anything you can bring, David, is there. Even a good, sophisticated thing with you. Thank you.
So with that as the final agenda item, I don't have any more business for today, Mr. Chairman.
Okay, great. Any other questions and comments? Again, just so we're clear on this, if you're gonna make, I would hope there are a few areas that you might make some adjustments in the writing of the report, so we know what we're reading as the final report.
We will, pending comments from the commissioners, we also have asked some other state agencies for some comments.
And then, yeah, so
We'll
give us
incorporate all
time.
that and distribute the final report with plenty of time for review.
I want to do this in the right way.
Great.
So on the 13th, we'll have both the public hearing and a full board meeting.
I think we will have some business to do, and then we'll move into the public hearing. I don't have at this point a clear idea of what the agenda will be, but it may be a little bit of a combination of both. A little bit of business, obviously, with the cost trends report, but I think the main bulk of the meeting will be focused on the benchmarks.
So it's 12 to 3, 12 to, because as I recall last year, the benchmark hearing went on for a considerable period of time, and we had a fabulous turnout of legislators, unless I'm having a hallucination.
We did jointly with the committee, right?
Yeah, so
We did.
we
did.
will-
It was terrific, but it also, took two and a half hours. So I think we're just,
Yeah.
Secretary and I are saying maybe we need to either start early and later, kind of give ourselves enough time to do both well.
All right, we'll be in touch as we schedule that. We will be inviting the Joint Committee on Healthcare Financing again to join us for that hearing. And certainly with those members involved in the hearing, we want to keep our other business potentially to a minimum, although they may be interested in the cost of the report.
Now, we're gonna have a brief executive, committee.
I assume we're gonna close the public portion of our meeting. So
We're
it's
gonna
gonna
close
be that-
this and we're.
That's correct, and we're gonna take a vote on whether or not to
Oh, yeah.
move into executive session.
So we're the first,
So just the purpose, as you are all familiar, is to enter executive session to discuss the performance improvement plan and be able to keep confidential the identity and the information provided around entities for which we're considering doing a performance improvement plan and to have those deliberations. And so the plan today is not to return to full public session once we take that vote. This vote, as always, will be by roll call, and you have the motion on slide 86.
Second motion.
Yeah.
everybody, we have to do roll call. Stuart?
Yes.
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 Great. And thank you to, oh, girl.